our CME coordinator for Sovah Health, and Jennifer Goodman, who manages our nursing CE credits. Welcome to a Sovah Health program. The program this evening will provide 1 hour Category 1 AMA CME credit to physicians and 1 hour of Virginia Association nursing CE credits for nurses and nurse practitioners. Sovah Health is accredited by the Southern States Collaborative, an ACC ME accredited provider. Similarly, the hospital is accredited by the Virginia Nurses Association to provide nursing CEs. The program this evening was developed with an effort to promote two desirable physician attributes, including patient-centered care and our using evidence-based medicine in the care we deliver. As far as commercial relationships of the both planners and speakers, Dr. Frank reports that he has a relationship or has had a relationship with Humanetics, where he served as a member of a scientific advisory panel. He's agreed to mitigate this relationship by providing his slides for CME office review, which was done, and there's no evidence of commercial bias, and attesting that any clinical recommendations are based on evidence-based medicine free of commercial bias coming from peer-reviewed literature and/or consensus-based guidelines. Dr. Cooper, myself, and members of the Sovah Health CME committee have no commercial relationships to report to you. This program does not have any commercial support. It is supported, as are all of our programs, by the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. Dr. Landis created this upon his retirement in 1985, and it serves to support continuing education for healthcare professionals in our communities. Dr. Landis was the founder of the Southside Nephrology Group, previously known as the Danville Urologic Clinic Nephrology Group. This evening, you will receive by email an evaluation form. Mary will also, as I'll show you in a moment, put in a QR code. You can access it. It has some 7 or more questions. We ask everyone to take a few minutes to complete this. Question number 4 asks, what changes will you be making or will you plan to make in your practice based on what you've learned this evening? That is a question for everyone, not just for physicians. We all practice our craft within our scope of practice. When you fill out this eval form, it will also ask you again for your email and your full name. Please do give us your full name, in as much as that form that you're filling out, the eval form, serves as the name for your CME certificate. So please, no nicknames or short names. If someone is participating, listening to the program this evening with you, and they have not individually logged on, please let one of us know that so we can be sure that they get credit for that purpose. We like to remind, and this is just, this is an example of the QR code. This will appear in the chat if you prefer to link to the eval form with that. We like to remind the residents on the call this evening, you do not have to keep up with your CME certificates. Your program coordinator, Dara Johnson, or Ms. Galvez will track your CME participation for you. I need to point out that the completion of an eval form for physicians is totally voluntary. It's not critical for you to receive credit. However, for nurses, the Virginia Nurses Association does require you to complete an eval form for nurses, nurse practitioners, in order that you can receive credit. Each time we do a program, I want to make the point to thank Mary Kent and Jennifer Goodman for helping organize this program. They really do all the majority of the work that it takes for us to put these together, and I'm very grateful for their help and support. I know that Dr. Frank encourages and invites questions, so if you have a question, but if you will put it in the chat, Mary will get that to him. When you're asking your questions verbally, once you've asked the question, please mute your phone to minimize feedback. You're welcome to ask as many questions. In fact, we love questions. Or if you have comments about the material, please do. But once you stop speaking, please mute your phone so we don't have the feedback. I want to highlight a couple of upcoming programs for you. This time next week, next Thursday night, we're going to have an update on osteoporosis, and diagnosis and management. There have been some new management strategies in the past year or more. Dr. Bob Adler, Dr. Robert Adler, is the lead physician for the Central Virginia Veterans Affairs program. He's chief of endocrinology and metabolism at the VA in Richmond, which is part of Virginia Commonwealth University. Dr. Adler is a national recognized expert in bone disease, and he's a really, really good teacher. The other program that we added literally this past week is a current update on the Virginia Department of Health recommendations for annual vaccines for children and adults. There's been a lot of, if you will, varying recommendations in the popular press in the past few months. And so we thought it would be helpful to get Dr. Baracco, who's the medical officer for the western part of Virginia in the VDH, to come and review what is being recommended by VDH for all of us that are citizens of the Commonwealth. That being said, I'm delighted to introduce Dr. Carnell Cooper to you. Dr. Cooper is the Chief Medical Officer for Martinsville, Danville campuses within Sovah Health. He is new to our institution, and having been with us a little over a month, and we are just so fortunate to have him. If you've not had the opportunity to meet him and review what his accomplishments are, they're remarkable. His undergraduate and medical school training were at Yale. This was followed by general surgery training, and then several years of surgical research, and then finally a fellowship in surgical critical care and trauma at the University of Maryland. University of Maryland is one of the premier shock trauma centers in the nation. After finishing his fellowship there, he also served on faculty in the shock trauma unit. More recently, he has served as chief medical officer at a number of large academic centers, and we are just so happy to have him this evening. He's going to moderate our program. And with that being said, Dr. Cooper, I'll turn it over to you. And Dr. Frank, if you want to bring your slides up while he's doing that, we'll be ready to go. Thank you so much.
Thank you, Dr. Moore. Good evening, everyone. It's my honor to introduce our speaker, Dr. Stephen M. Frank. Dr. Frank completed his undergrad and medical school training at the University of Missouri in Kansas City. After completing an internship at the Mount Zion Hospital in San Francisco, he completed a residency in anesthesiology and a fellowship in anesthesiology and critical care at the Johns Hopkins Hospital. He then began what has been an outstanding career, ascending to the rank of professor in the Department of Anesthesia and Critical Care Medicine. He has authored over 200 peer-reviewed journal articles, book chapters, invited review articles, monographs, and books. He's been an invited speaker to conferences around the world and is a member of numerous professional societies. He has served on editorial boards of professional journals, including Anesthesiology, Transfusion, and the International Journal of Clinical Transfusion Medicine. He is currently the director of Johns Hopkins Health System Blood Management Program and director of their Center for Bloodless Medicine and Surgery. Despite these demands on his time, his commitment to teaching and mentorship, which has been recognized by the medical students and residents at Hopkins by awarding him with 2 Teacher of the Year awards and a research mentorship award. His talk this evening is entitled Evidence-Based Transfusion Practice and Blood Management Programs. Dr. Franks, thank you for joining us.
Thank you, Carnell, and thank you, Michael, for that kind invitation, and thank you for inviting me to give this lecture tonight. Without any hesitation, here we go. And all good talks need a disclosure slide, and this is mine. Perhaps the most important disclosure is a potential bias in my talk, because I personally had a life-saving transfusion in 1988, and I want to start with that story. So this is me. This is my bike after a head-on collision with a Mercedes-Benz. I was helicoptered to Maryland Institute of Shock Trauma, which I understand is where Dr. Cooper did some training. And at shock trauma, they removed a ruptured spleen. And if it wasn't for 6 units of blood, I probably wouldn't be here today, because I left the hospital with a hemoglobin of 7, and I calculate that I lost my entire blood volume. So there's no doubt that blood saves lives. In fact, I was invited to tell my story of my life-saving blood transfusion to Congress. During the pandemic, we had such a severe blood shortage that Health and Human Services made a plea to Congress for support for the blood industry. And I was going to show the picture of my abdomen and my bike, but they didn't like that. So I took the opportunity to show my 2 French bulldogs and my Hopkins tie-dye t-shirt. So there you go. So there's no doubt that blood saves lives, and we see signs in our elevators in the hospital all the time, like this one: give blood, save a life. So how come in the last 15 years, shown here, across the United States, how come we've seen a 33% drop in blood use? We've gone from 15 million units of red cells a year down to 10 million units. And this is a dramatic decrease in blood use. And I hope to explain why this is happening in the next few slides. In fact, blood use is down to such an extent that the blood industry is hurting, because anytime you sell 33% less of your product, no matter what it is, you're going to have trouble making ends meet. And that's where the blood industry stands right now. And part of the story begins back in 2012, when the Joint Commission held their Overuse Summit. And they named blood transfusion as one of the top 5 overused procedures in U.S. hospitals. In fact, it was also the most commonly performed billable procedure in U.S. hospitals, and overused, for example, just like antibiotics for the common cold, which was also on the list. And this is based on evidence that I'll show in a minute. And then along came Choosing Wisely. If you were practicing in 2014, when this national campaign evolved, you might remember Choosing Wisely was designed to reduce unnecessary tests and procedures. And now we have 6 national societies, including the ICU doctors, the anesthesiologist, the hospitalist, the hematologist, OBGYNs, and even the blood bankers themselves are aiming to reduce unnecessary transfusion through Choosing Wisely goals. And one of the best things about a blood management program is you can achieve all 3 of these at the same time. You can reduce risk, you can save cost, and you can improve outcomes. And we're going to go through risk, cost, and outcomes in the next few slides. So this is what we think the current day risk is with transfusion. So luckily now, hepatitis C, for example, is thought to be rare, about 1 in 2 million chances with transfusion. HIV is about the same, about 1 in 2 million. So these risks are not zero, because if we give 10 million units of red cells, that means 5 people will still be exposed to these potentially fatal viruses with a transfusion. And then we have the not so rare events like hemolytic reactions, which are most often from wrong units being given, which occurs more frequently than we would like. And then TRALI, transfusion-related acute lung injury, can occur in about 1 in 5,000 transfusions, and is thought to be 10% fatal. But then we have the common events with transfusion, like TACO, transfusion-associated circulatory overload, which is now the #1 cause of transfusion-related death. So people are happy that Hep C and HIV now are so rare with transfusion. They've been compared with the same incidence of getting struck and killed by lightning in a serious study by Jeff Carson. Those chances are about 1 in 2 million. But we forget about Taco and Trelly, for example, which are much more common and the number 1 and 2 causes of transfusion-related death. What about cost? So when we started our blood management program about 10 years ago, this is what we were spending on blood acquisition cost at Johns Hopkins, about $28 million a year. And you can see we were spending over $1 million a month on red cells. We were spending about $1 million a month on platelets, but only $1 million a year on plasma and cryoprecipitate. So our initial goal was to reduce our blood use and blood expenditure by 10%. So if we do that, you can see we would save almost $3 million a year. And I must add that the true cost of blood to bring a unit all the way from donor to recipient is about 4 times higher than the cost shown here, because there's a lot of overhead cost as well. I also add that we're poorly reimbursed for blood. In fact, we're paid about 3/4 of the actual cost of the unit. So it's definitely a money-losing deal. Okay, so we're lucky now that we have what I call 12 landmark trials that all show what I call less is more for transfusion, because over the last 25 years or so, we now have all these randomized trials, all in the New England Journal or JAMA, that all support these hemoglobin triggers shown here on the left, between 7 and 8, even in critically ill ICU patients, septic shock patients, cardiac surgery patients. And when these randomized trials compared to higher triggers of hemoglobins of 9 to 10, they found either the same outcome, meaning no benefit to giving extra blood, or a worse outcome in 4 of the trials, meaning actual harm to transfusing to higher hemoglobin levels. So I like to say less is more, but with a caveat, until 2024, because you might or may not know that we now have 4 new randomized trials all in the last year. And I'll show you these real briefly. So these are new hemoglobin trigger trials. The first one by Jeff Carson is for acute myocardial infarction, called the MINT trial. And what they found is there was a borderline significant better outcome with a p-value of 0.07, favoring the hemoglobin trigger of 10 compared to 7 or 8 for patients having acute myocardial infarction. So we're not sure what to do with that p-value of 0.07. And the same is true for traumatic brain injury, because we had 3 RCTs all come out in the latter half of 2024 with traumatic brain injury, subarachnoid hemorrhage, or acute interparenchymal hemorrhage. And these randomized trials, one of them showed a borderline significant better outcome with a hemoglobin trigger of 9 compared to 7. The other showed a significantly better outcome. That's the TRAIN trial, better outcome with a hemoglobin trigger of 9. And then the Sahara trial showed no difference. So I'm going to conclude that with these new trials in the last year, that ischemic or injured heart and brain may benefit from higher hemoglobin triggers of 9 or 10, as opposed to the 7 or 8 supported by the older studies. So potentially more is more, And most of the experts are saying we should treat the whole patient and not just their hemoglobin value alone. So we were interested in hemoglobin triggers, and back in 2009, we were getting data from paper records. And then in 2010, we switched to electronic anesthesia records that look like this. And we had every single unit of blood and all the hemoglobin values entered into electronic database that we were able to query. So we ranked all the surgeons on the left and all the anesthesiologists on the right at Johns Hopkins according to their average hemoglobin thresholds for transfusion. And we found this wide variation in practice, about a 3-gram variation in hemoglobin triggers. And our paper was written up in the media about this wide variation in practice for transfusion during surgery. And they noted a need for improved blood management, and also noted that blood transfusion is one of the most common procedures performed in US hospitals. And note that this showed up in the business section of the newspaper, meaning there was a huge cost savings opportunity if we could reduce variation in practice. So then we took the hemoglobin threshold graph and we put names on the y-axis. We did this for surgeons, and we also did it for anesthesiologists, and then people paid more attention. In fact, we even added the shaded zone up the middle, which is where the red bars should fall according to the 2 largest trials at that time. And you can see there was a lot of over transfusion going on, higher than the evidence-based range. So then we put the data on the door, and if you put doctors' names on a bathroom door on a rank order bar graph, I guarantee you they will line up to see where they stand compared to their peers. And that's exactly what happened. And by the way, this is the anesthesia office bathroom door. So it wasn't truly a public display, but nonetheless, everybody wanted to know where they were compared to their peers with their hemoglobin thresholds. And then I tell at this point a story about a surgeon number 44 with his permission. He was one of the most senior surgeons at Johns Hopkins. He had just finished his 2000th Whipple procedure. And I sent him an email on Christmas Day. I had nothing better to do. And I said, look, you have the highest hemoglobin in the hospital among your transfused patients. His next Whipple case, he told my anesthesia colleague, he said, if you hang that blood, Steve Frank will be all over our case. So he either heard about the data on the bathroom door, or he didn't like being on the edge of the curve, which is exactly where he stood. And after we showed him the data, his transfusion rate for red cells dropped by more than half. And surprisingly, his plasma and platelet transfusion rates also decreased because a lot of people think, oh, if they need the red cells, they need the plasma and the platelets to go with, which is true for massive transfusions, but not necessary for patients getting just 1 or 2 or 3 units. So that's the power of electronic record data, if you can use it to your advantage to improve practice. And the other use of electronic record data we showed was to optimize preoperative blood ordering. And by that, I mean type and screen and cross-match before surgery, because back in 2013, we had a shotgun approach to ordering blood, and anybody and everybody could order blood or not. And we had not much rhyme or reason, a lot of better safe than sorry ordering for patients who didn't even need a type and screen. So we updated our surgical blood order schedule back in 2013 using real data. And it was the first time we'd updated this list in over 30 years, believe it or not. And we showed a huge potential cost savings because, for example, robotic retropubic prostatectomy under urology, that's a robotic prostate surgery. I'm sure you've seen these. We don't even do a type and screen now for those because we had one patient out of 1,000 that was transfused for this type of surgery. And we would say, okay, if you get that one patient in 1,000, you either send a type and screen, which can be done within an hour, or you can give them emergency release or what we refer to as O negative blood, which is, we learned back in 9th grade biology, is a universal donor. And guess what? That hasn't changed. You can give O negative to anybody. And patient blood management has been called giving the right dose of the right product to the right patient, the right time for the right reason. For example, if you can give $5 worth of iron pills and avoid $500 worth of blood, that just makes sense for treating pre-op anemia. In fact, sometimes we even get aggressive with intravenous iron or even erythropoietin before surgery, because wouldn't you rather show up with your own red blood cells instead of requiring someone else's? And then less invasive surgery, like I said, the major difference with robotic surgery, whether it be prostate or hysterectomy, or even pancreatic surgery we're now doing robotically, the major difference is bleeding and transfusion with the robot. It is dramatically less. And that's one of the reasons for that 33% drop in blood use across the country, is surgery has gotten much less invasive and much lower transfusion rates. Cell salvage, or the cell saver, I'll show you a picture of one in a minute, has been called the centerpiece of blood conservation. That's where we give patients their own blood back during surgery that we collect during the case. Topical hemostatics, minimizing phlebotomy, we'll talk about that in a minute. Clinical decision support, those are the annoying pop-up alerts that tell you when you're ordering blood outside of guidelines. I'll show you those in a minute. Tranexamic acid or antifibrinolytics are being called a game changer. I'll show a couple slides on that. Point of care testing like thromboelastography or TEG. Anytime you have a rapid turnaround test, you're not waiting and wondering if your patient needs blood, and you're less likely to give an unnecessary transfusion with a rapid turnaround test. Audits with feedback and education like we're doing right now. So I'm a cyclist, and one of my heroes was Lance Armstrong, and his drug of choice was erythropoietin. In fact, we give EPO to our patients. Sometimes we tell them, don't worry, it's legal for you. You won't get in trouble. And it turns out, though, that we give a lot more iron than erythropoietin, because the most common cause of anemia in the US and the world is iron deficiency. So when there's not time for oral iron, if you only have 4 to 8 weeks before surgery, oral iron might not make that much difference because it's very poorly absorbed. So often we go to intravenous iron, and the two best iron compounds are the low molecular weight iron dextran, called Infed is the trade name. You can give a single dose of 1 gram in one setting, which is a huge dose of iron, more than your GI tract can absorb in about a month. And then we give iron sucrose sometimes to our inpatients, which is the cheapest iron compound with the least side effects. These ones to the right are really expensive. Like carboxymaltose can be over $1,000 a dose, and isomaltose is even more expensive. So we try to avoid those. So this is what a cell saver looks like. The cell saver was invented in the late 1970s. During the 1980s, when HIV was prevalent in the blood supply, everybody wanted cell saver blood. No one wanted banked blood. If patients could get their own blood back, that was the first choice. And cell saver blood is still one of the best methods of blood conservation during surgery. So we've even shown that cell saver blood, shown in green, has normal 2,3 DPG levels, the same as fresh pre-op patient blood, shown in dark blue. But stored blood or banked blood, shown in light blue, is about 95% depleted in 2,3 DPG, which causes a left shift in the hemoglobin oxygen curve. So banked blood is left shifted, which means that it cannot easily offload oxygen to the tissues because the affinity is too high. So cell saver blood, however, is the same as fresh patient blood because it hasn't been stored in the blood bank. It's only been outside the body for maybe an hour or two. We don't store it for up to 6 weeks like we do banked blood. So this small paper we had must have been a slow news week because the media picked up on our paper and said that giving patients back their own blood is a higher quality transfusion compared to red cells from the blood bank. And we still think, I haven't met a patient yet that wouldn't rather have their own blood back compared to someone else's. So what about phlebotomy blood loss? We took a survey in the 5 adult ICUs at Johns Hopkins, and we found that the average patient loses about 60 mLs a day to phlebotomy. And that's just over 1% of a typical 5-liter blood volume, which is about how much erythropoiesis you have every day. You destroy and create about 1% of your red cells. So you're basically canceling out any benefits of erythropoiesis by sending this much blood to the lab. And then in the neurocritical care unit, where they use these inline devices to return the wasted discard, they were able to cut the blood loss in half. And we've since switched to smaller phlebotomy tubes pretty much across the entire hospital now. We use the medium-sized tubes, which is we call pediatric tubes here, that hold between 2 and 4 mLs. You can see the adult tubes hold between 5 and 10 mLs, and we don't use those much anymore. And then sometimes we even use these really, really small tubes for neonates, for example, or Jehovah's Witness patients. And they only hold 0.5 mLs, which is 1/20th of the blood that the largest adult tube contains. So what about best practice advisories, or what we call clinical decision support? I call these annoying pop-up alerts, and I don't like them myself, but I designed this one. And this is designed to tell you when your patient has a hemoglobin above 7, and there's an advisory that they might not need a transfusion unless they're actively bleeding or hemodynamically unstable. And we even referenced the 2 largest trials at the time with a hyperlink if you want to read the randomized trial. And then to proceed with the transfusion, you have to pick a reason. And the most common reason is active bleeding, because we all recognize that you have to stay ahead of the bleed, even if your hemoglobin is, say, 9 or 10. If you're actively hemorrhaging, you have to treat hypovolemia, probably with a transfusion. And then symptomatic anemia is the second most common reason. Tachycardia, hypotension, dyspnea, because we treat the whole patient, not just their hemoglobin value. And we've shown that clinical decision support, like these pop-up alerts, they really do work, because along with education, like we're doing right now, we went from 1,000 units a month down to 400 units a month of red cells that were given outside of guidelines. That's a 54% decrease. And at the same time, we saw a 14% drop in overall blood use among the surgical services at Johns Hopkins. So what about tranexamic acid? Because it's being called a game changer now in the orthopedic world, also in the blood management world. TXA, we call it, costs about $20 a gram, which is a typical dose. And when we started giving it to our joint replacements back in 2014, we saw this dramatic decrease in blood use. At the same time, however, 2 of those big randomized trials came out showing that less is more for hemoglobin triggers. And also we hired 4 new surgeons. So if you look at TXA on a global scale, it decreases bleeding and transfusion by about 30%. And 2 of the largest RCTs ever in the world, with 20,000 patients each, were both about tranexamic acid. The CRASH-2 study was in hemorrhaging trauma victims, and they showed about a 10 to 15% decrease in mortality with tranexamic acid. And in the woman trial in postpartum hemorrhage, they showed an even greater decrease, 20 to 30% decrease in mortality from postpartum hemorrhage with tranexamic acid. And neither one of these studies showed an increase in thrombotic events, which is also important. Also in cardiac surgery, a large randomized trial in 2017 showed a decrease in bleeding, a decrease in transfusion, and now tranexamic acid is pretty much standard for all cardiac surgeries with a bolus and an infusion, because these are longer cases. So for our blood management program, we had our clinical analytics team build these dashboards. And from these dashboards, we generate reports that we send out every month. And the reports look like this. So every department gets their own report. This is an example for orthopedics. I like to pick on orthopedics. And on the x-axis is the number of red cells that each physician ordered for the month. And on the y-axis is the individual physicians. We started with numbers and then we switched to names. And you can see the real information is green, yellow, red. Green is hemoglobin triggers less than 7, yellow 7 to 8, and red was above 8. So you can see, for example, the second from the top physician had 80% of their transfusions in the red zone, but the 6th one down had no transfusions in the red zone. So it sets up a friendly competition among your peers to do better. And this really did make a difference. And then the chief of surgery said, Steve, you should put names on these graphs instead of numbers, because people will pay more attention. With her permission, we put names, and indeed, people were more interested in the data. And I have to remind them every now and again, this is not mortality. This is not morbidity. This is simply a hemoglobin trigger. So don't get all upset if you see more red after your name. And then on the left side, we have single unit red cell orders in green and double unit red cell orders in red, because we now have a single unit transfusion recommendation. I'll talk about that in a minute. So we noticed at 3 of our hospitals in our health system, we had a very high double unit transfusion rate. But at the other two, we had a much lower rate of double unit transfusion orders. And so we launched about 10 years ago the Why Give Two When One Will Do campaign to advocate single unit transfusions. And if you went to med school when I did, back in the 80s or 90s, we were all taught that the dose of blood was 2 units. If you're going to give blood, you give 2. But then along came Choosing Wisely right here, and the experts in the field started to advocate for single unit transfusions and then reassess the patient. So we took the Choosing Wisely message with the Why Give Two When One Will Do slogan, and we put this message on screensavers throughout the institution. And whether or not you go to grand rounds or whether you work in the day or the night, you would see these screensavers pop up. And we were one of the first quality improvement measures to use screensavers. Now we have all these other quality improvement programs that are doing the same. And it does really, really reach a broad audience. And so we showed that the Why Give Two When One Will Do was very effective. You can see the red bars are double unit transfusions, green or single units. At monthly intervals, we had a pretty dramatic decrease in double unit transfusions. And now we're down to 15% of double unit transfusions. We were as high as 66%. So once we got our program up and running in the first 3 years, this is the decrease in red cells, plasma, and platelets that we were able to achieve. And we also had the best practice advisories for plasma and platelets using the INR threshold of 1.5 to 1.7 and the platelet count trigger of 50,000, where you get a pop-up alert of perhaps out of guideline transfusion orders. So we reached our goal of the 10% decrease in cost. And this is how much money we saved in the per year. This is how much money we were saving after the first 3 years of launching our program. And we reached almost a $3 million cost savings a year in blood acquisition costs. So I'm going to cover 2 more outcomes and then we'll wrap it up and have questions. I want to talk about outcomes at the extremes of transfusion. For example, how do patients do when they don't accept transfusion, like Jehovah's Witness patients? We call them bloodless medicine patients, and I'm going to show you how they do, because they get what I call extreme blood management, where we pull out all the stops. And then how do patients do after massive transfusion? You ever wonder how patients do after 5 coolers of blood? I'm going to show you how they do. So we have a program for patients who don't accept blood, primarily Jehovah's Witness patients, but there's also some for personal reasons or alloantibodies to red cells who can't be transfused. And so we took the first 1,000 patients that received bloodless care and compared them to a standard care group of controls. And when we looked at morbid events, we saw no difference in ischemic, respiratory, renal, or thrombotic events, but we did see a lower incidence of hospital-acquired infections in the bloodless patients. And this makes sense because we know that banked blood has an immunosuppressant effect and can predispose patients to hospital-acquired infections. So if you can avoid transfusion, we found a lower incidence of infection. We also found that cost per case was 8 or 9% less with the bloodless care, because blood is expensive and infections are also expensive. So overall, patients did as well or better when we pull out all the stops, like pre-op anemia treatment, cell savers, tranexamic acid, even just keeping patients warm during surgery is a good way to reduce bleeding. Controlled hypotension during surgery, smaller phlebotomy tubes, all those things combined into a bundle really benefit the patient. And we've had a few poster child patients like this one who gave me permission to show his picture along with his wife. He came in with a GI bleed. He was Jehovah's Witness, and he and his wife adamantly refused transfusion, and his hemoglobin dropped to 2.1 at the nadir on day 2. And we had another patient like him that had a nadir hemoglobin of 2.8 from a GI bleed. And this young man, he was put on comfort care in the ICU because the ICU team and the MICU was convinced he was not going to survive without a transfusion with a hemoglobin of 2.1. And lo and behold, after high dose intravenous iron, erythropoietin, B12, and folate, tranexamic acid to stop his GI bleed, and minimizing phlebotomy. See, some days we didn't even draw his blood on the dotted lines. And he left the hospital in about 2 weeks with a hemoglobin of 6. He really beat the odds. And both of these patients suffered from chronic anemia from their GI bleeds, which was in their favor, actually, because you can be preconditioned to tolerate anemia. When you're chronically anemic, you tolerate a lower hemoglobin level than if you run normal hemoglobins. We never thought this would happen in 2012 when we launched our program for Jehovah's Witness patients. Now we have 14 publications with obstetric patients, GI bleed patients. We have methods papers on how we treat them with doses and frequencies of these erythropoietic medications. And it's really been a very fruitful area. And what we've learned from our Jehovah's Witness patients is now benefiting all the other patients, even those who accept blood, because we're using the same methods of blood conservation for everyone now that we've learned from our Jehovah's Witness patients. In fact, we showed recently, after 10 years of doing this, we had a 7.5-fold return on investment for our comprehensive blood management program. So in the bloodless patients, we're attracting them to the hospital where they might have gone somewhere else, but we cater to their needs, and we're bringing in about $5 million a year in revenue, a net margin revenue. And in the blood savings category on the bottom, we were saving about $5 million a year. And then they increased the cost of platelets in 2022 by about 30% for various reasons. And now we're saving $3 million a year. So overall, for every dollar we spend on our blood management program, we're saving $7.50 in return. So I told you I'd look at more outcomes after massive transfusion. And what we did here is we took every single patient admitted to Johns Hopkins over a 6-year period, and we plotted them based on their dose of blood on the x-axis in 10-unit increments. And then we put mortality on the y-axis. And of course, we knew that patients getting more blood were more likely to die because they're sicker patients having bigger surgeries. But we didn't know the slope or shape of this curve. And it turns out the shape is linear and the slope is 1. And if you remember algebra, that means that for every 10 units of blood, we had a 10% increase in mortality. And at 50 units of blood, we had 50% mortality. So it's like flipping a coin, for example, when you get to 50 units of red cells, if the patient's going to leave the hospital alive or not. But maybe more important is the types of morbid events that these massively transfused patients suffer from. It turns out infections and thrombosis are way more common than renal, respiratory, or ischemic events after massive transfusion. And that makes sense because I already described the immunosuppressant effect of banked blood that can put you at risk for infections. But also banked blood is prothrombotic. The cells are slightly injured or damaged during storage. And so banked blood doesn't flow well through small capillaries and can put you at greater risk for thrombotic events. So I'm going to wrap up by saying blood saves lives when you need it, but only increases risk and cost when you don't. So it's our job to give it when needed and not unnecessarily. And pressure patients' prayer, proline, plasma, and platelets. Here's surgeon number 44. His name is John Cameron. He did 3,000 Whipples when he did his last one at age 82. And this is how he says you stop surgical bleeding. And with that, we could either take questions or I can tell you a lesson learned from expert witness work.
Dr. Frank?
Maybe I'll show you this real quick.
Okay.
Because I'd rather learn from other people's mistakes than my own. And I can tell you right now, don't be afraid to use O negative blood. I reviewed a case of postpartum hemorrhage death, which I call the worst thing that can happen in a hospital. And the type and scream was not completed. And they asked the anesthesia team and the obstetric team if they would rather give uncross-matched blood. That's what they called it, because the cross-match wasn't finished. And they said, oh, no, we're not going to do that. We're going to wait for the cross-match. Well, meanwhile, she bled and bled and bled, and it was too late by the time the cross-match was finished. And if they had just given the uncross-matched blood, which is, by the way, another name for O negative, the patient probably would have survived. The other name for it is emergency release, which sounds equally scary as uncross-matched blood, but it's just 3 different names for O negative, which I learned in 9th grade biology was a universal donor, and that's still true. Another case I reviewed is they ran out of blood due to a snowstorm, and another postpartum hemorrhage death in a small town. The lawyer asked me how much blood a hospital should keep in the blood bank, and no one has the answer to that. But if you're doing labor and delivery, they only had 6 units of type O blood. And you know, if a patient is type O, they can only get type O. And they only had 6 units, which is not enough. And they couldn't get more because of the snowstorm. And those are lessons learned from reviewing legal cases. And with that, I think we have time for questions.
Okay, we do have some questions in the chat. And so I will just start reading them to you, if you'd like. The first one is from Catherine Parker. She said, thank you for the CME. I am the administrative director of the laboratory at Sovah Health and wanted to know if you have recommendations for the use of O positive or type specific Rh positive blood for Rh negative male patients or female patients older than childbearing age.
Oh, that's a hot topic right now. So I did say that emergency release or uncross match is O negative, but for females of childbearing age, we recommend O negative. But for everyone else, including women over age 50 or male patients, you can give O positive for emergency release, and you will not have problems, for example, with future pregnancies like you might have in young women. There's a whole controversy going on right now because of whole blood in trauma. Whole blood is coming back for trauma, and the trauma surgeons are convinced that you can save lives by giving whole blood rather than individual components because it has plasma and platelets included in the bag. However, all whole blood in the US is O positive because there's not enough O negative to go around. And it's very controversial whether the benefits outweigh the risk in giving O positive to young women.
Okay. Dr. Moore, did you want to ask your question or do you want me? Okay, can you explain how tranexamic acid works? May have mispronounced that.
Sure. Yeah, there's no S in tranexamic acid. Even people in the blood field are saying tranexamic acid, but it's really tranexamic acid. And how does it work, I think was the question.
Yes.
Okay, so it prevents the breakdown of clot by inhibiting plasminogen going to plasmin, which is the fibrinolytic enzyme. So by preventing clot breakdown, it stabilizes clot that is already formed and decreases bleeding. Okay, so it doesn't generate clot, it just prevents clot breakdown. So it's an anti-fibrinolytic. And it really is a game changer for postpartum hemorrhage, orthopedic surgery, cardiac surgery, and trauma.
Okay. The next question, as Sovah itself has a blood donation center, and the blood donated is used within the community, does this help decrease the hospital costs on products?
Oh, that's great. You can collect your own blood. Yes, if you do it right and you do it well, you can decrease cost because blood is voluntarily donated. We don't pay donors for their blood. So it makes sense, but there is a large overhead included for collecting, for storing, for viral testing. There's 7 pathogens that all blood is tested for, not just HIV and hepatitis C. We still test blood for syphilis, for West Nile virus, even babesiosis, which is a parasite from mosquitoes. Or no, deer ticks, I'm sorry, like Lyme disease. West Nile, it comes from mosquitoes. But there's an overhead with testing and storing and even transfusing blood. Cross-match, type and screen is a bunch of overhead. But you can save money if you run your own blood donation center and do it efficiently.
Okay. Dr. McIntosh has a comment question. Good evening. Excellent presentation with helpful updates, Dr. Frank. Beyond the guidelines, what institutional or systemic changes could we implement to better support evidence-based decisions at the point of care? Thank you.
Sure. Well, the simplest, most effective campaign that we've discovered is the Why Give To When One Will Do campaign. Because oftentimes the doctors want to give the patients something, okay, for their hemoglobin. And we were all taught back in the 80s and 90s to give double unit transfusions, but now the experts in the field are saying no, single unit and then reassess. So that's the simplest, most effective intervention. To look at hemoglobin triggers is a little trickier because you need time stamps on the lab results and then a time stamp on the transfusion. And so you're looking at hemoglobin before the transfusion, not after. And so to make those green, yellow, red graphs is a little harder to do. But the YGIV 2 and 1 will do is the simplest, most effective thing that we did. And unless you know your double unit transfusion rate, you don't even know your potential blood or cost savings.
Okay. Dr. Bassaretti asks, can you advise on topical applications of tranexamic acid and its costs?
Yeah, so tranexamic acid is usually given intravenously. You can also give it orally, by the way, which is how they treat menorrhagia patients now with oral tranexamic acid. But I'm forgetting what the main question was. I got off track.
Oh, it's okay. He wanted to advise on topical applications.
Oh,
and the
topical, yeah.
cost. Yeah.
So in orthopedic and joint replacements, like hip and knee surgeries, there is evidence that shows efficacy for topical tranexamic acid. And some surgeons are injecting it into the joint space for hip and knee replacements. And it is effective, and it is an alternative. And if patients have a thrombotic event history, some people are leaning towards topical because there's still some fear in giving tranexamic acid in patients with thrombotic event histories.
Okay, so we have one from Dr. Lewis, of our great residents. This question may be more for our surgical team, but do we have the cell saver machine? If no, what would the process be to obtain one?
Yeah, so a lot of smaller community hospitals either don't have a cell saver or they contract out for cell saver services, which means someone comes to the hospital with a cell saver as needed, and they charge a lot of money for that service, like $600 just to show up with a cell saver. So contracting out is more expensive. Cell savers are losing popularity because of tranexamic acid and because of pre-op anemia treatment and because of tolerating lower hemoglobin levels based on those randomized trials. So, and surgery is less invasive, right? So cases that used to need a cell saver perhaps are now going robotic. And so the cell saver is losing business to tranexamic acid, if I had to summarize briefly.
And the final comment, at least at this point, is from Dr. Singh, wanted to say happy anesthesiology day to you.
Oh, today's Ether Day, because yes, in 1846, this day in history is when ether was first demonstrated at Mass General under the ether dome. So thank you for bringing that to our attention.
And she also thanked you for a very informative presentation. And that is all that's in the chat. If anybody else has a question that they'd like to open their mics and ask, now's the time.
Dr. Frank, that was a great presentation. You mentioned the controversy about some data more recently saying that 9 or 10 may be okay, and you sort of summed it up by saying treat the whole patient. So what else should we then be considering when we are making that decision? And is it, or whether they're an event or not? What other factors? I mean, there are a lot of factors out there to consider, but what would be your top 3 or 4
Yeah.
factors?
Sure. So intravascular volume is really important. If someone is tachycardic, hypotensive, oliguric, okay, and down on volume, then if you pour 2 liters of crystalloid in them, their hemoglobin's going to drop maybe 2 grams, right?
Hmm.
So that patient might need blood at a higher hemoglobin level than the patient who has a normal volume status. So intravascular volume is really important. Like I said, tachycardia, hypotension, oliguria, or dyspnea on exertion. So that's what I mean by treating the whole patient rather than just their hemoglobin level. And if they're chronically anemic, they will have much less symptoms with their acute anemia because patients adapt to being anemic. So those are things that we look at. Oh,
Great, thank
active
you.
bleeding, of course.
Sure. Yeah, absolutely.
You have to stay ahead of the bleed.
Sure.
And active bleeding comes in all shapes and sizes, right? From a very slow ooze to a real hemorrhage.
Great, thank you. Wonderful talk.
Well, thank you for the compliments and for the invitation.
Well, this is Dr. Moore. Let me jump in and just thank you also, Dr. Frank. I think everyone's truly enjoyed the presentation. And one last, is there any other comment or call before we let Dr. Frank get back to all the great stuff he does at the Great John, as we call it? Okay, well, we won't try to keep you any later. Dr. Cooper, thank you for serving as moderator. We really appreciate it. Let me remind everyone, we hope you will rejoin us a week from tonight, same time, same station as they used to say on TV before cable. And we'll have Dr. Robert Adler here to talk about current management of osteoporosis. So that being said, hope everyone has a great evening. Thank you for being with us. It's been a pleasure. Take care and good night. Bye-bye.
Thank you, everyone.